if people, instead of taking an early retirement, instead go into this direct primary care model, then you have physicians practicing longer and you're alleviating the physician shortage, right? So why keep physicians, why handcuff us into this third-party payment model that is really driving people crazy?
Welcome to Healthcare Liberty Labs with Tiffany Ryder, where we teach you what they don't want you to know about healthcare.
I have to admit that I am deathly terrified of neurosurgeons, just in general, as an artifact of having to call them in the middle of the night from the emergency department, especially as a young clinician who had no idea all of the answers that I should have before waking up a neurosurgeon in the middle of the night. And anyway, but I followed you for a couple of years now, and I've read many things that you've read or that you've written on X and on LinkedIn and professionally in other venues. And I love the energy that you bring, and I love hearing you more recently really dive into the discussion of primary care and direct primary care, specifically this subscription sort of cash-based model for care. Because as a neurosurgeon, I don't understand why you care. Right? It's fascinating to me that you are so invested in sort of bringing this message to the forefront when clearly you have no financial interest, no personal interest. So there's something philosophical or moral about your intrigue. And so I'd love to hear more about what you think about primary care and how you sort of got roped into this.
The love I have for direct primary care models is really twofold. One is I see the dysfunction in the system currently. So when I see patients in my clinic, I say they need some sort of follow-up with primary care. They may not have a neurosurgical problem. Their back pain is not surgical, but they certainly need primary care follow-up. And the wait list is, 6+ months long just to get a primary care appointment. So I see that dysfunction in the system every day. And then, in seeing that dysfunction, I really tried to get an understanding of just what makes the whole system work. And that's led me down the deep, dark path of reading a lot of economics literature and finding out how systems are financed. And in doing so, realizing that the best way is probably just direct subsidies. They work really well as a social safety net. And so the analogy that I always come back to are food stamps, right? Food stamps work so well because it's a cash equivalent. There's minimal involvement of a third party, which means that the beneficiary receives most of the benefit. They're accepted at almost every food establishment. So as somebody who gets food stamps, you're not regulated to a safety net grocery store. You can go to the same grocery store that anyone else can. And that really gives a substantial amount of access. And that is something that's missing from people on Medicaid. They don't have the same access, right? And so why should I, someone who has private insurance, be able to get a cash equivalent in the form of an HSA, a tax advantage cash equivalent that I can then use to gain access to primary care outside of the traditional insurance market, yet poor people can't? And so to me, that seems as a real disparity. And so I've worked a little bit on looking into this with Anish Kokut and Josh Umpert, who is, of course, Atlas MD, I think is everyone knows him, who is on X at any time, and really seeing that if you want people to get access to primary care, the best way, instead of making this Byzantine system that we know as Medicaid that has poor reimbursement rates and a lot of bureaucratic burden, is just give them a cash equivalent and get access to primary care. And because it's insane that we look at using insurance models to pay for something that's predictable and routine like primary care. And so again, the best way I think is just to do it as a cash equivalent, so food stamp type benefit, an HSA that people can then use to get primary care. And then hopefully my patients wouldn't have to wait 6 months to get a primary care appointment.
Wouldn't that be nice? That's always...
That would be.
This episode brought to you by Crowd Health. Crowd Health helps you find awesome doctors, negotiate your bills, and fund those bills through our peer-to-peer funding platform for less. Welcome to an easier way to pay for healthcare.
I mean, that's the anxiety provoking thing. I would say, I used to tell people, I don't really do medicine in the emergency room. I make phone calls. I make phone
Right.
calls and I teach my patients like how to work the secretary and what the magic words to say are to get an appointment, hopefully in 5.5 months instead of 6 months. Right. And
Exactly.
I want to circle back because I've never heard that analogy before, and I kind of love it. I really do. I know that recently there's been just a ton of people. I'm trying to not be condescending, but like crying and throwing fits and being like dramatic on TikTok and throwing these like moral arguments as if anyone who believes that the Medicaid system needs, I don't know, some changes, someone to look at it, maybe some reform, is evil. And Medicaid is not simply helping people gain access to healthcare. Medicaid is this huge bureaucratic thing that is sort of funneling money to, United Healthcare and Blue Cross or whoever's managing these programs, and really restricting access, underpaying the physicians who are doing the hardest work with the most challenging patients, and no one really talks about that. I never see a news program where they're saying, oh, well, we really have a problem. There's too many people really skimming off the top. Why don't we just give direct primary care vouchers to people who are Medicaid eligible? And why don't we let those people just sort of like work it out and bring it to whatever doctor they want? And isn't that real access to care? But somehow that makes me a bad person, because I just read recently in one of the most well-known medical journals that we have in this country that direct primary care is actually bad for people.
Yes, the New England Journal article, that was, I have a little bit of issue with that.
So I thought people were overplaying it, but you read this article on direct primary care, and essentially there's just an attack on this idea of private physicians that I've actually heard socially before, but didn't think anyone was taking seriously. So, what do you think about that? What did you think about the article? What do you think about the argument that was made?
Yeah, so there's 1.1 million physicians in the U.S., and a significant amount are retiring early or leaving the profession because they don't like the way it's functioning right now. They're burdened with all this paperwork, administrative duties. And then if you look on the other side of the physicians we're training, there was a very interesting article that came out of Elsevier where they interviewed med students, and over half of medical students don't plan on practicing clinical medicine. They want to be consultants or work in public health, et cetera. There is the root of your physician shortage. Physicians leaving the insurance-based market, the third-party payment market, and going into direct primary care is not a substantial factor for your physician shortage. And if that would keep physicians practicing longer, if people, instead of taking an early retirement, instead go into this direct primary care model, then you have physicians practicing longer and you're alleviating the physician shortage. If you then give people access to that model who couldn't otherwise afford it in the form of direct subsidy, all the better, right? So why keep physicians, why handcuff us into this third-party payment model that is really driving people crazy? And I'm a neurotrauma surgeon. I am never going to exit the third-party payment model. So this is not self-interested in any way, as you mentioned before. I'm not going to make a direct care neurotrauma program because that's just financially ridiculous. But my services should be insured, right? Nobody sets aside money for the encounter with a neurosurgeon. So I'm going to forever be, but that's the purpose of insurance. And then if you have insurance focused and tailored for what it's actually meant to do, what the actuarial tables have laid out the finances for, then you don't need all this extra bureaucratic intermediaries to get people access to routine, predictable services like primary care.
Yeah. And It's hard to have these like free market conversations without being accused of being
Evil.
political or
Yes.
right or biased in some way. But if you look at, I don't care who's in charge, red, blue, any color, government money going into a private system always changes the dynamics, right? And I would argue that it always makes things more expensive. It drives the prices up. It changes the supply and demand. And what I really feel like we're seeing in healthcare is that because we have insurance and because I'm like, well, I paid $1,500 for my family to have health insurance, uh, you're damn right you're going to pay for my, I don't know, Botox for migraines. And I don't care if I could
Right.
just go pay $400 for it myself and call it a day. I'm going to miss 8 days of work to do this paperwork and all of this stuff so that my insurance will pay for it because I deserve it.
Mm-hmm.
And what we're starting to see now, and I love this on social, is we're starting to see like those phone calls where the person is calling and saying, well, I got my ambulance bill and it was $600. And I just wanted to make sure that you know that I actually have insurance. So can I give you my insurance card? And then, the patient hands over their insurance information and they say, oh, no problem. Actually, it's $3,200 now,
Right.
and your deductible is $1,800. So you owe us $1,000 more. And it's like, I think the average consumer of healthcare just has no idea of how those market dynamics work, of the fact that there's a charge master at all, of the fact that you as a neurosurgeon can, save someone's life, and that surgery can cost $20,000 or it can cost $80,000. And it has nothing to do with how motivated you were in the OR. It has to do with things that you probably don't even know about that happen
Right.
well after that patient is home and cozy.
Exactly. And I think it's something that people also don't realize is if you actually have commercial insurance, over 2/3 of people who have commercial insurance are actually the payer is not the insurance company, it's your employer. Right. So if we get back to free market principles, there actually is room to negotiate there because the insurance company is just acting as a TPA, a third party administrator. And so it's your employer that's paying that bill. And so you can actually negotiate a little bit through your HR department on how much you are paying. And that's why there is some downward cost pressure. And people like to rag on insurance companies to say they're collaborating with the hospitals to raise prices, et cetera.
I do a little bit of that.
Yeah,
But
I know.
maybe I'm
And that's,
wrong. I want to know.
yeah, no. And that, if you look at the standard, the way that the medical loss ratio is written, I think it's easy to make that argument, especially if you're looking on, like the capitated plans like Medicare Advantage. But in the commercial market, again, 2/3 of people, the employer is actually the one footing the bill for all those costs. So there is a lot of motivation for your employer to get the best deal possible, right? So they don't want to pay that list price. They will try to negotiate down a good deal. And that's where you can really see these effects of the free market with these direct contracting agreements. Dutch Rojas speaks a lot about this. We just had on our podcast, we had Heath Villeman on, and they do a lot of work in this direct contracting market because there's employers that are sick of paying those high prices. And so if they have an alternative method, direct primary care, surgeon-owned ambulatory surgery centers or surgeon-owned hospitals, things that can offer an alternative to the standard large health system and their inflated prices, you do have a lot of free market effects there that can drive down the costs of care. And then you, as a beneficiary, if you don't like all the denial paperwork and all that, go through your HR department. They actually would have a little bit of pull to be able to say, like, we're actually the ones footing the bill. It's not you, United or Aetna. It is company X that is employing us, and we want our beneficiary to get that MRI. So stop putting up roadblocks and just and we'll pay for the darn imaging study. They can also help direct you to lower priced cash pay equivalents. For example, if you get a quote for an MRI and it's $18,000, these are real numbers that I've seen before at a large health system. Meanwhile, down the street, the same MRI is $600 at a cash pay equivalent. Just go there and tell your employer that, hey, maybe we should look into direct contracting with this cash pay surgery or imaging center instead of sending everyone to the high priced health system.
Yeah, I don't think that. I almost wonder sometimes if it's like almost the way people feel about the IRS, right?
Hmm.
Like maybe you're not even willing to hire a CPA or look into, what could be done to lower your tax burden, because at the end of the day, you decide, well, there's just nothing I can do about it, right? It's
Yep.
me against
Yep.
the system. Everything is sort of opaque and difficult to manage. And I wonder if a lot of even employers find themselves in that place where they're trying to run their business. They're trying to, I don't know, manufacture tires,
Right.
and they just want the broker to do what the broker does, which is where we really run into these non-transparent fee arrangements where the broker's getting payments from the insurance company instead of just the fee from the company. It's a mess. What arguments do you see in this, or what validity do you see in these arguments around access and the changes to Medicaid?
Yeah, I mean it's a big topic, and the
It is.
specific. Yeah, so the specifics of the one big beautiful bill are one thing, but I like to try to set what I would want the standard to be and see how we can get there. I think the most important thing about getting access is lowering the per unit cost of care, right? And so you mentioned a DPC that can offer care for $60 a month. That's fantastic. We can get more of that. Then these conversations matter a lot less because we're not going to be paying these exorbitant prices. And just by decreasing the unit cost of healthcare, more people are going to be able to have access with their out-of-pocket expenses.
Mhm.
And so, if you break up all of these regulations that give a thumb on the scale to large hospital systems that drive up the cost of care, that will decrease the unit cost of care. If you reform some of the regulations about Medicare participation and allow people that are physicians that are in Medicare to offer a DPC offering to Medicare and Medicaid beneficiaries, that would decrease the cost of care, right? Because right now, if you are a Medicare provider, if you are signed up in Medicare, you can't offer DPC to
Yep.
Medicaid and Medicare. You can't offer a cash price. So in order to offer that to Medicare and Medicaid beneficiaries, you have to opt out completely of Medicare, which means that you're limited on if you can take locums coverage, cover ERs, et cetera.
And I
Um,
think that's a really important point that I just want to highlight for people who are, maybe don't speak like total healthcare speak. But what you're saying is if you are a physician, you're a family physician, and you're accepting these government health insurance programs, Medicare and Medicaid, that you're not allowed to take cash
right.
for that visit.
from
Yep.
those patients. You can't even
Yep.
offer them a cash price. So if you have to bill for a Medicare beneficiary, you have to bill through CPT and get whatever the Medicare reimbursement is for that office visit. You can't offer them a cash price. I mean, it doesn't make any sense. It would severely, by getting rid of that regulation, you would improve access to care. Going back to that New England Journal article you mentioned, the fact that people can't simultaneously participate in Medicare and offer a DPC, I mean, is ridiculous. There's neurosurgeons that, there's few of them, but there are neurosurgeons that have opted out of Medicare because they would rather offer a cash price and the access that comes with that to Medicare beneficiaries for their neurosurgical services rather than continue to participate in the program. But in doing so, you've now reduce their ability to, again, cover ERs or do locums
Yep.
coverage and cover things that actually need coverage like trauma.
Yeah. And I think the important part of that, for a patient who's listening, is that what we're saying is that there's no, I don't want to say valid reason, but there's no inherent reason that this can't happen. It is simply because this is the rule that has
Yep.
been established. It's not like, oh, well, if I do that, then I can't afford to keep my doors, all open and my lights on. It is literally just, well, I'm not allowed because mommy said no. Um, right? Which is a
Yeah.
problem. And
Yeah.
and the other problem I have with that particular thing, and then I will stop interrupting you and let you finish the list. But the other problem I have with that is that it takes away choice from the patients. And
Yep.
I mean, my real issue with the healthcare system is that clinicians, administrators, everyone really likes to say, oh, well, it'd be really nice if that patient would just manage their diabetes or just not be obese or just take some personal responsibility for the bad lifestyle choices they're making. But then out of the same breath, we've designed this system that really tells patients to just sit down and shut up and do whatever we tell them to do, and we're going to tell you what you have to pay. We're going to tell you how you can pay, and we really don't facilitate any autonomy. And without autonomy, what do I care? What do I
Right.
care if I can't
Yep.
change anything and I'm just little and you're just going to push me around the chessboard? Then there's really no incentive to try. Anyway, that was my soapbox, but so
So that's one way you decrease access, right? Is
yep.
the fact that these physicians can't. And then the other way is, these large hospital corporations, they will buy up independent practices and increase the prices that they charge, right? So if you have Dr. Bill's primary care clinic and they're an independent clinic, they bill from the physician fee schedule. If they are then purchased by large hospital system, now all of a sudden they bill from the outpatient physician fee schedule, which includes a facility fee. So now just the exact same service, the cost has gone up because they're billing a facility fee on top of their professional fee. So the cost of just providing the care goes up. And then you get all the other things that come with large hospital systems, the 340B subsidy, the GME subsidies, the fact that they can do, they're now tax exempt, so they're not paying taxes back into the community. So there's all these financial levers on the side of the large hospital system that puts independent physicians out of practice. And by doing that, you consolidate into these large systems. They have more leverage over the payers. They have more leverages over the small businesses, the self-insured plans. And so the prices go up. And so you have all these things that are favoring increasing prices, nothing that's really tamping down the prices. So if we fix a lot of that, then you get more of those doctors out there saying, hey, I will offer primary care at $60 a month. Then a lot of the issues that we have about Medicaid would be a lot less. The other issue is that if you are eligible for Medicaid, you can't participate in an ACA subsidy plan. The way that the rules are written is that you can't get an ACA subsidy. So you're essentially locked out of the private market and all the things that come with the private market. You are forced to go into Medicaid. And we have a lot of places, a lot of states, because Medicaid is essentially a state-run program. A lot of states have continued to expand Medicaid beyond even what the expansion was in the Affordable Care Act. There have been some statistics out there, but about 40% of Medicaid spending is on populations that are optional after the Affordable Care Act. If you include the ACA beneficiaries as optional, which they technically are because states have the option to expand to the ACA beneficiaries, then you could say about 60% of Medicaid spending is on optional beneficiaries. So 60% of Medicaid spending could actually be probably redirected to the private market at a lower price, giving people more options for care. And not locking them into this system that really provides a benefit card, but doesn't provide much else than that.
Yeah. And who's not optional? So let's review that population of who Medicaid was originated to serve.
Yeah. So the original patient population for Medicaid in 1965 was essentially the disabled, the elderly poor children, and poor pregnant women were those essentially four populations. And then with the passage of the Affordable Care Act, states had the option to expand Medicaid to anyone under a certain federal poverty limit. So the healthy poor could be expanded into Medicaid with the ACA. And then states have gone further. There's other populations they've started enrolling. For example, in some situations in California, you can get Medicaid up to 400% of federal poverty limit. States have included things like the working poor, undocumented immigrants, other patient populations that aren't even covered under the ACA statute. And about 40% of Medicaid spending goes towards those populations. And those populations could, again, if we've decreased the unit cost of providing healthcare, those patient populations could probably be insured via other means. I know especially the working poor, the Medicaid, the ACA Medicaid expansion beneficiaries, we spend about $7,000 a year, give or take, on insuring those individuals. You can actually insure them cheaper in the private market. And again, if you were to to take away some of the requirements on health plans and make them so you could get, say, a catastrophic plan again. You could get a healthy 35-year-old poor person a DPC coverage, a catastrophic plan, and an HSA, a government-funded HSA benefit at cheaper than $7,000 a year. And then they're able to grow this HSA year over year and have a nest egg and have something, an ability to grow wealth sponsored by the government, again, a cash equivalent that also acts as a motivator to stay healthy, right? If you're seeing this HSA grow year over year and know that you get access to it anytime you need it, you're also going to be motivated to stay healthy and not spend it. So there's lots of ways we could cover people better, cheaper, and give them more access.
Yeah, I love that you brought that up because I've heard a plan like that discussed, and it's mind blowing, right? And it totally, I think, discredits this moral argument, these moral gymnastics that you have to fight through when you say, no, I don't want Medicaid for all. Like, no, because I want people to have health care.
Yeah. and along those lines, people love to point to other countries and how well they do it and et cetera, et cetera. Singapore, what I just described about a government-funded HSA is what Singapore does. And Singapore achieves universal coverage to that. So basically, if you have employer-sponsored insurance in Singapore, part of your insurance benefit is mandated to go into an HSA that you control for elective spending. And then if you aren't employed or you can't make that contribution, then the government funds your HSA for you. So we love to say, oh, these other countries do it great. It's like, yeah, Singapore actually does it very well. I love their system. Another one that does it well let's do that. Another one that does it very well is Switzerland. So Switzerland has universal coverage. There's no equivalent of Medicare or Medicaid in Switzerland. It's all private insurance companies. You're forced to sign up for one. If you can't afford it, the government pays for it for you. But there's no government run plan in Switzerland.
Interesting. I am somehow not familiar with that. I lived in Germany for almost a decade. And I think, I think now is the perfect time to bring that up again in defense of primary care. And I want to get a little bit into physician salaries and income, because that's always something I fight pretty hard on that box because the arguments are ridiculous again. But I think that the biggest difference of what I noticed in Germany, which, by the way, I was privately insured and with American health insurance, which means all I had to do was pick up the phone and a doctor would see me at any moment, anytime. I paid my bills in cash when I would go in. And I remember my primary care physician charged me 23 euros. It was 23 euros to go in and see the doctor. And they did the whole, they were percussing on my stomach. It was the full physical exam. And, people say, oh, well, did you have good healthcare in Germany? And I said, well, yes, of course I did. Some of that was due to the fact that I had private insurance. And so I got to cut the line. Some of it was due to the fact that I have recently learned that, Americans are funding most of the profits for pharmaceuticals. So when I needed a medication, I could afford it because the contracts between the pharmaceutical companies and the vendors in other countries are advantageous to those countries. So cool. Yep. But I think beyond all of that, there's this huge, Teufelskreis. Now I'm talking about German and all I can think of is in German, but there's this circle that goes on where primary care in this country really sucks. It's awful. And it is not because the primary care physicians are bad. It is not because inherently PAs and NPs are idiots. It is because no one can effectively treat diabetes and heart failure and Hashimoto's and 8 other conditions in 7 minutes. And also, those primary care physicians are not greedy bastards. They just have to pay their staff. They have to keep the lights on, So primary care really does become this thing where it's like, I don't really have time for that. You can go to endo for that. You can go to, this other specialist. So people aren't getting great primary care. in the States. Culturally, we all know that. We all know that it sucks to take a half day off work and sit in the waiting room and then get your 7-minute appointment with a doctor who's just, depressed and really frustrated and, behind schedule. So it's almost like we have terrible primary care. So then as a culture, we've decided that only specialists matter. Like, I want to go to the cardiologist for my blood pressure medication because otherwise, I have to deal with this Yahoo that I can't ever get an appointment for or with. And so we've sort of developed a culture where we don't value primary care. We only value the high cost care across the board. I can't get into primary care, so I go see an emergency medicine doc. Like, we're creating a system that doesn't do that. So I think there's an argument that says, well, why not? Why not just give Medicaid for all? And then, at least people have access to primary care. On the surface, right, in fantasy land, I do think that that's a great answer. But I think in the reality that we live in, that is not what would happen, as we discussed. But how do we navigate? Essentially, there are health reforms that need to be paid attention to, but how do we navigate the health reforms, the financial reforms, the getting physicians to go into the specialties that we want, and changing the culture around how we utilize healthcare and how we utilize the healthcare system, and put some responsibility back on the patients? I mean, it's like 50 moving parts.
Yeah, I mean, you totally fix society with one bill, right? No, I think you're right. A lot of it has to come culturally, and I'm seeing that happening more and more. I'm seeing, with the so-called silver tsunami of Medicare beneficiaries, I'm talking to more and more that are like, yeah, I just pay direct primary care out of pocket. I paid into Medicare my entire life. I realize that this benefit is not going to cover my routine needs. It's basically a catastrophic plan at this point, and they realize to get access to care, they're going to have to go and pay direct primary care, or they join some vertically integrated system and do it that way. So I think a lot of the culture is changing. You have a lot of employers, like we mentioned before, that are realizing that direct contracting is going to be able to keep things, their prices down and get patients better access. You do have more physicians starting their own ambulatory surgery centers and even physician-owned hospitals. And if we can get the moratorium on physician-owned hospitals lifted, I think you would get a lot more competition in that space as well. So I think the culture is starting to shift. Walmart's a great example, the Walmart Certificate of Excellence program. So they will, for Walmart, they'll drop all your cost sharing requirements as a beneficiary if you decide to get your obstetrical care at one of their centers of excellence, or your spine surgery at a center of excellence, because they know that these are centers that they can trust with good outcomes and low costs. And so they will, for spine surgery, this is actually really cool. They'll pay for you and a loved one to travel to one of these centers of excellence from wherever you are, if you're a Walmart employee, to get your care there, because they realize that there's good prices and good outcomes, and they want to try to direct people to those physicians. So I think there is a bit of a shift coming. More and more people talking about the benefits of free market in healthcare, because we've seen what Medicare for all would do. We see what's happened in single payer countries like Canada and what's happened to their wait times, and realize that that's just not that's not something that we want.
Yeah, it's horrific, right? I mean, but still, I interview people on the streets. I do a lot of social content for different people, and you ask people, and they're like, "Let's just do it like Canada." You're like, "Oh, do you want to wait 18 months to see your doctor?"
And I think when you bring up the Medicare for all, the way the legislation's written, or the fact that they want to copy Canada, and you start explaining what that actually means to people, what it means is that you don't have a private option. So direct primary care would essentially be illegal under the current Medicare for all legislation. The way it's written, they're copying the Canada model and providing medical services outside of the government-sponsored program is illegal. And that's what happens in Canada. You can't have direct primary care in Canada. And that's what they would want to do with Medicare for all. If you don't make it illegal, if you don't make it compulsory. Then what it essentially is a public option that everyone pays into, and those with means would go outside the system because they're not going to want to have those wait times in those poor facilities. So you would essentially create a two-tiered system if you had a public option. Which is what's happened in a lot of European countries like the NHS.
That's what we have in Germany.
Yeah, exactly. Yeah. And in Germany. And so if you look at the UK, right, it's about a quarter of Brits now have private insurance because they realize the NHS just isn't working for them. And so they're paying all this money into a system that they're not using. You've created a two-tier system. And it's just, I think it ends up being kind of the worst of both worlds. And so if you're talking about Medicare for all or a public option here, you're either looking at the Canadian system, which is really severely restricting on your personal freedom, both as physicians and patients, or you're looking at a system like the NHS, where you're going to have a lot of people that just want to opt out and pay out of pocket for private insurance after paying a whole bunch of money into this system that doesn't really work. So I don't think either of those are good. And that's why I keep coming back to the free market. It's really the only thing that makes sense. And again, if you want people without means to have access to it, give them a direct subsidy. As Milton Friedman says, the problem with poor people is they don't have any money. So give them a direct cash-based equivalent so they can get into it. Yeah, into the private market. And there's always, and I'm a big believer in the safety net. Again, I work for a county hospital. About a quarter of my patients are homeless, and I think there is a patient population that even with a cash-based equivalent are not going to be able to sign themselves up for healthcare and make their appointments and all that. And then you can have a safety net program like Medicaid, but Medicaid should be so focused on those people and not trying to take care of your average healthy 35-year-old working poor person. They should be taking care of the people who really can't navigate the system and focused on that so it can do that part really, really well and let everyone else reap the benefits of the free market.
Yeah. How much better could we serve people if we were focused on what we needed to focus on?
Exactly.
So I've heard the argument that we're really through these state Medicaid expansions, it's almost as if these states are attempting to create, especially California, not to pick on your state, but attempting to create sort of a Medicaid for all.
Single payer.
Yeah, single payer platform, like without actually like doing the work to get buy-in and actually do that. Do you think that has validity?
Yeah, I think that they'd like to create a public option at least. Without going through, like you said, without going through the democratic process and getting it debated in the legislature and passed and all that. Yeah. In California, about 44% of people are on Medicaid. And again, we've expanded it to a lot of populations that would not otherwise be eligible for it. Another example is we eliminated the asset requirement. And so as long as you don't have a high income, it doesn't matter if you're sitting on millions of dollars in assets, you can qualify for Medicaid here in California. And what that really affects is the long-term services and supports community, right? So somebody with, Alzheimer's or brain injury, which we see, they may be sitting on a few $1 million worth of property, retirement accounts, et cetera, if their family then signs that person up for Medicaid, then that protects those assets so the family can inherit them and so that the Medicaid program can't recoup them for all the costs that they take up, right? So somebody has Alzheimer's, they live in a memory care facility for 5 to 10 years at the end of their life. Medicaid traditionally has a claim on their assets after death to help recoup some of those costs, but California has gotten rid of that. And so those assets can then be protected for inheritance for the next generation. And I think this kind of like slow shift has made people more accustomed to Medicaid as being a payer, right? And so if grandma's on Medicaid and is taking care of her assisted living, then Medicaid can't be that bad, right? And hey, look, by the way, now we get to inherit all those assets later in life, And of course, it sounds cruel if you're talking about going after grandma's assets after she's died. Yes, that sounds terrible. But on the other hand, there's people that can't get access to care. And so if you're not going after those assets, you're now depriving someone else who actually needs Medicaid to fund their care, not having the appropriate resources to do so.
Yeah. And also your medical assistant that, is grabbing vitals for your patients on a clinic day, or the nurses in the OR, like they're funding that. It's not magic money that comes from nowhere. It's an issue. So I want to talk a little bit about salary, and I am not talking about your salary, even though the entire internet was talking about your salary, including your wife, which was lovely. But I wrote an article a couple of years ago about this shortage in primary care just because it drives me nuts. And again, from the ER, not being able to send my patients anywhere and feeling the weight of if I don't do a great job managing whatever thing that really isn't my job to manage, then this patient may just be shit out of luck. This is not acceptable.
Right.
And anyway, and my issue with this primary care shortage, my personal issue when I graduated from school, I started medical school in Germany and then came back here and then ended up going to PA school. So in PA school, for those of you who don't know, basically once you finish, it's your job to work under the care of a physician. And if that physician is a neurosurgeon, then I am a neurosurgery PA. And if that physician is an emergency medicine person, then that's what I do. So I go out into the marketplace. I did very well in my rotations. I had lots of options and opportunities, which I'm proud of. But I really wanted a generalist position. I wanted a position where I could learn about all the different body systems and get just sort of a good base and then be able to decide that I wanted to specialize later on. So the specialties that I considered were emergency medicine and primary care. And they were both interesting to me, but I really felt drawn to primary care. I grew up without insurance and in an area where there was low health literacy. And I just loved this idea of going into a primary care office and serving in these rural environments and helping people understand their bodies more. It sounds cheesy, but that was exciting to me. And there's two reasons that I didn't do that. And I think both of them are the reason we have a primary care physician shortage. The first was I literally was able to make more than 2 times as much money working in the ER. And the second is a little off topic. I'll bring it up, but I don't know if we have time to really circle back. But I was sold this story as a PA that, oh, you don't need a residency. You don't actually need to go to medical school because you're going to study medicine in this way. And then you're always going to have your best friend available to you who's going to help you navigate things, when stuff gets squirrely. And what I found on rotations, even as early as rotations, is that the physicians are totally available to help. But also they're doing the job of 1.5 physicians plus helping you. And really that these big hospital systems just want you to be able to function just like a physician. They just want to pay you less money, right? And so those were the two issues that kept me out of primary cares, because in emergency medicine, at least I could see my doc, right? And primary care, you were on your own. But really the idea of paying back, $200,000 in student loans on half the hourly wage because I have a big heart just didn't work for me. And I see the same thing when I look at physician salaries, and it makes me wonder if we think that primary care would actually save money, right? Overall, because if I keep my patient healthy and out of the ER or, I don't know, a general surgeon's office somewhere getting an amputation for their diabetes, their diabetic foot, that saves the system money, then why are the CPT codes, why is our system set up to pay primary care so much less than every other specialty? And I'm curious if you have thoughts on the Medicaid or the decreased payments to physicians from these government-sponsored programs, on how we value an RVU, how we value different services by different clinicians. And I think it's something that it's really hitting everyone hard, but I think physicians are suffering more than anyone else.
Yeah. So how much do you want me to go? Because I can explain the CPT and RUC process if you'd like.
I think it would be nice, just because there are certainly holes in my knowledge, and I talk to people like all the time. And I'm still like, well, how does this work? So I think it's good for people to understand. And then I guess I would just really love to hear what you think could be done about it. I know you're active at the AMA and you're active, obviously, in conversations with other physician leaders about how we can address that, because I don't think it just affects you. It affects our patients. It affects access. It affects whether I can, get into primary care or not.
Yeah, I think so. A big part of it is that the job of a primary care physician is not all that gratifying right now, because you end up doing a lot of paperwork and not a lot of what you signed up for, which is patient care. And so one thing is exiting the third party payer market, or exiting these large health systems that, if you're a primary care doctor working for a large health system, you're just there to refer within the health system and keep patients from, this quote unquote leakage that happens.
Hmm.
The way primary care, the way all physicians get paid was, once you're a government contractor, there's essentially price setting. And that's done through the CPT and RUC. Those are both committees within the American Medical Association. CPT creates the codes that are used for billing, and the RUC then values those codes. It's nice that physicians control that process, but despite us controlling it, it still is a central planning process. And so the codes that are used to reimburse primary care are typically what are called E&M codes. This stands for Evaluation and Management. And those E&M codes are, the outpatient codes, the new patient codes, the returning patient codes, and then they can be used for inpatient services as well, like an ER E&M and a inpatient consult E&M, or admission to the hospital E&M. And so those prices are essentially all set by the RUC. When the RUC sets a value for a CPT code, that value has to be accepted by CMS. CMS tends to accept most of the RUC's recommendations. About 5% of the time, they may change it a little bit and take their own value. But once RUC makes a value for an E&M code or any CPT code, CMS accepts it, and then that is the value for that code when you bill Medicare or Medicaid. Insurance companies tend to go off of those RVU values as well, and they may pay 120% of what Medicare pays, but the RVUs are typically still the same. And of course, when you get into direct contracting models and things, with insurance companies, there's accountable care organizations, there's per member per month arrangements that you can there's a whole bunch of different arrangements that you can pay primary care, which is nice if you could get more to that free market. What is a primary care doctor worth to Walmart, or to the local employer in the neighborhood, or to you as a person who's paying out of pocket for DPC? All right. So the more we can have those rates setting what primary care gets reimbursed, and less of the central planning way, then I think you're going to really get a shift of people's values and the prices reflecting what people value. I'm actually a big fan of letting physician assistants practice in primary care. And, if you as a PA put up your office and you charge one rate and people really want to access at a low cost, they may go to you. If they really want to see a physician and they're willing to pay a little bit more, or maybe wait a little bit longer, they may choose a physician. But give patients that option, give them the choice, and then really allow the market to tell us what we're worth. And that's the problem, is when you have rate setting, when you have central planning and centrally set prices, you don't know what the actual value in the market is. And the other issue with the E&M codes is I can bill codes for brain surgery and spine surgery, and I can bill the E&M codes. So those E&M codes are not specific to primary care. In fact, they have very few codes that are specific to primary care. Mm-hmm. Right. So most of the codes that they have access to, I also have access to. So if one day CMS wakes up and says, we're going to decrease all the spine and brain surgery codes by 95%, and we're going to use that to up all the E&M codes, then I'll just go and do more clinic. Right. And most doctors will, because now all of a sudden we'll have access to all these E&M codes. And so you can't really, it's, again, problems with central planning is that if you're trying to value one group of physicians more than the other, all you're going to do is shift physician behavior instead of actually reimbursing our primary care colleagues what we think that they are worth. There's no easy way to do it. There have been adjustments over time, when they redid the E&M codes under the first Trump administration. There was a Patients Over Paperwork initiative to decrease the amount of administrative burden documentation associated with E&M codes. And then at the same time, they also increase the reimbursement for those CPT codes. But all that did was take, kind of just shifted the money around and took a little bit of money out of the specialists and put it into the primary care providers. But it certainly didn't fix the issue, because clearly we're still having it. So again, the more we can get to the free market and showing what patients and employers and people who are utilizing healthcare actually think their primary care is worth, then we're not going to really know how much we should pay in primary care. I agree with you. I think they should all make a lot more money, and they should have a lot better quality of life in their jobs and do a lot less paperwork. But that's going to be hard to get to. Yeah,
I agree. It's funny because you were explaining this so eloquently, and what I heard is yada, 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 price controls, yada, yada, central planning, yada, yada, shortage, right?
Yep.
And it's like, really, if you take out like all the detail, it's not surprising that we have a shortage when we have price controls, like fixed pricing from a central, entity. I did some light internet stalking about half hour before we got on here, and found that you, at least the internet said that you did a fellowship at on the Hill. Is that true?
I spent a little over a month with Senator Bill Cassidy in his office. I was a resident in Louisiana. He actually came to our state neurosurgical society meeting and gave a talk on free markets in healthcare.
No way.
I was very inspired by that. And so I was able to chat with him afterwards. He invited me for a chance to come and, kind of see behind the scenes for a little over a month. He often has physicians come through as these visiting healthcare policy experts. And it's really nice. I mean, he is just a fantastic guy. I really enjoyed my time with him. He knows his stuff pretty darn well. And again, he does care about the patients and his constituents. I mean, he was going out of his way for these initiatives for these patient populations that are never in a million years going to vote for him, but still just doing it because he obviously cares.
It's really, really good to hear, like, especially like in a time where everything feels so divisive and everyone's so frustrated with Congress. Like, it's great to hear that you spent time there and that was a positive experience. I'm also from Louisiana. Where did you do your residency?
In New Orleans at LSU.
New Orleans. All right. And then the other thing I wanted to ask you about was Dr. Keith Smith runs a surgical center that
Surgery Center of Oklahoma.
Yeah. So, tell me, as a surgeon, do you know Dr. Smith? Have you visited the center or heard, good things? I'd just love to hear, I guess, as a surgeon, not necessarily as a neurosurgeon, because you're always going to be attached to the hospital. But, do you see a move in the surgical world to start actually looking at this as a viable option?
Yes, absolutely. So I don't know Keith Smith aside from our interactions on Twitter.
Yeah, that's where I know him from.
Yeah, I mean, his surgery center is very inspiring. I got exposed to him first from the Akkad and Coker report. If you've never listened to that podcast,
I haven't. But I will now.
They no longer do it, but it's kind of one of the first podcasts that got me into healthcare policy and this sort of free market angle. Okay. They're very much fans of Mises and Hayek, and it's a great listen. So Keith Smith was one of their guests, and that was the first exposure I had to the Surgery Center of Oklahoma. Keith has also been on Econ Talk, which is one of my favorite other podcasts with Russ Roberts. And they had a great discussion on, he has cash prices only. You go on the website, you look up the cash price. I think that there's more room for this, even in neurosurgery. So there in Buffalo, there is a neurosurgical ASC, ambulatory surgery center, that has really pushed the envelope and is doing more even neurosurgical procedures as outpatient procedures, which ironically, if we're talking about how Medicare increases prices, they can't do that for Medicare patients because a lot of those procedures are on Medicare's inpatient only list, which means you can't do them as an outpatient. So for example, they're coiling aneurysms, they're taking out small brain tumors as outpatients, and they're showing that it's safe. And they have fantastic outcomes. The surgeons love working there because the turnover time is great. The facilities are fantastic and they're part owners. So they have, they're invested in this, which I think the more physicians are invested in the delivery of healthcare, the better it's going to be. Yeah. But because of Medicare's rules, they can't take a lot of Medicare patients there because Medicare has a list of procedures that can only be done inpatient. And if you try to do that in an outpatient setting, they won't let you. But what they are doing is they're getting the private payers to contract with them. They're getting direct contracting with local employers because they're showing these great outcomes at low cost. So I think even in neurosurgery, there is room for this. And again, the more we have this, you're not going to replace my trauma hospital with a surgeon-owned specialty surgical center, right? Yep. But the more you can do these specialty surgeries at the surgery centers where you have low costs and good outcomes, the more, again, you could focus my hospital on doing the things that it does well, which is trauma care and serving a underserved community in San Francisco. But you offload it, you get other people access to care at a low cost with high quality outcomes. I think there's a ton of room for that. And people are starting to see that. And I think Keith Smith has been one of the pioneers. There's a lot of physician-owned ambulatory surgery centers, even physician-owned hospitals from spine surgeons that are just showing how efficient and how good the outcomes can be with physician leadership and physician ownership. And again, once we get rid of that moratorium, hopefully on physician-owned hospitals, and it wouldn't just be physician-owned ambulatory surgery centers, but it can be physician-owned hospitals as well, which just allows it to do not just outpatient procedures, but a few inpatient procedures also. And again, they don't have to be, your physician-owned hospital doesn't have to be a quaternary trauma center. It can just be a spine hospital or neurosurgery hospital that does cases that occasionally stay 1 to 2 days in the hospital. It doesn't have to be some sort of all-encompassing thing. And just being able to do that at that level of competition would just, again, drive down that unit cost of providing healthcare for everyone.
Yeah. I love it. I'm so excited. I'm really happy that we got to, touch on 1,000 different topics. I hope this is the first of many conversations. But for people who are interested in following you, where can they find you? I just found your podcast a few weeks ago, and I'm loving that.
Yeah, so our podcast is The Doctor's Lounge on Substack. It is also should be on Apple and Spotify by the time this airs. My personal Substack is also The Doctor's Lounge, and then on Twitter it's at Dr. DiGiorgio, X now at Dr. DiGiorgio, and then my comic book explainer on how healthcare works is offlabelideas.com.
Yeah. So that one's new. I'm excited about that one. It's just great. All of these have great energy.
I appreciate that. I was trying to write an explainer for how healthcare works, and I just couldn't figure out how to write it with text only, because to capture the absurdity, I really needed a graphic novel format. So that is being released slowly.
I totally get it. I think it's great for, people who are working in the industry, but also, med students, like nursing students, people who are interested. I mean, I think we all had some idea that it wasn't going to be perfect, but it's still, but we did it anyway. Like, there are easier ways. This is my argument. I had to make my argument for why physician salaries are not too high, but there are so many ways for intelligent people who are willing to work hard and go to school for way too long to make money, right? There's so many easy ways for that particular human to make money. And the fact that we do have people who are naive enough to go into medicine despite the dumpster fire that it is, right? Or who are passionate enough to overcome that is pretty incredible. And I'm grateful that people are still showing up to work and that we do have care for the time being. And I just hope that we can inspire some of these, I believe, free market changes that really have the potential to change things in an environment where, I think it's getting bad enough that even the most committed to the status quo are going to be willing to start looking around. So thank you.
I hope so. Yeah, it's been my pleasure. Thanks for having me. Thanks for all the hard work you're doing.
This has been the Healthcare Liberty Lab. Thank you to our listeners and our sponsor, Crowd Health, for making this possible. Be sure to subscribe wherever you listen to your podcast, be it Substack, YouTube, Spotify, Apple, or somewhere else. We're glad to have you with us on this mission to rethink healthcare together.